everyone, my name is Dan and I'm a mental health pharmacist, and today I'm going to be doing a relatively quick presentation about psychedelics. I have 4 major objectives to today's presentation, so hopefully by the end of the presentation you're able to differentiate between the types of hallucinogens based on mechanism of action and terminology, hypothesize the diagnosis for a patient based on DSM-5 criteria, compare the hallucinogens between each other, and finally debate some of the positives and negatives based on current literature. I also have a table of contents slide that will help to guide us through the presentation today. We'll start with some background, then we'll go into some of the effects of the different hallucinogens, then we will look at a few studies, and finally just a slide or two in summary. So without further ado, let's go into the background. First, what is a psychedelic? So psychedelics are psychoactive substances that alter perception and mood. Within psychedelics, we often subclassify the different types of hallucinogens. The major groups that I'll be going over today, first are the serotonergic-like group. This group has a structural similarity to serotonin, and they work on serotonin receptors. And this includes LSD, psilocybin, mescaline, and DMT. After that, I'll go into some detail about the dissociative group, and this group works on NMDA receptors. And finally, I'll go into a group that is a little bit different than the others because it has hallucinogen effects, but also has stimulant effects. This isn't a full list of psychedelics or hallucinogenic substances. There are a lot more chemicals that can cause these symptoms. First, I wanted to start with a knowledge check because I think the terminology is very important here. So a patient says that they have used Molly in the past. Which hallucinogen is this patient referring to? Ayahuasca, DMT, MDMA, or psilocybin? So feel free to pause and think about it for a second, but the answer is MDMA. So in regards to terminology, hallucinogen is the most common term in scientific literature. With that being said, psychedelic is more of an informal term used by the general population, so you can hear them mixed and matched. I will be using mostly hallucinogen going forward in this presentation. I do think the nicknames and the street names are quite important to know because some of these names are used more commonly than the actual name. For example, I commonly hear patients talk about acid when referring to LSD, so it's good to know that connection. Anything related to mushrooms, shrooms, magic mushrooms is probably psilocybin product or psilocin product. Next, anything related to cactuses, buttons, peyote is mescaline products. DMT, I don't generally see patients who use all that frequently, and I don't hear the nicknames that often. PCP I don't see all that often either, but I have heard angel dust in the past. Ketamine is next. I sometimes hear these nicknames. Dextromethorphan, I often hear robo tripping, things like that because of the branded cough syrup Robitussin has dextromethorphan in it. And then MDMA, I commonly hear these names more than MDMA. So I commonly hear ecstasy, commonly hear Molly. So I do think it's important to know this because this is maybe what your patients will be saying, so it's good to know what they mean when they say certain nicknames. So what are some of the psychedelic effects? So one thing is altered thinking. It can change how your brain perceives different thoughts. Altered sense of time, and this could be time slowing down or time speeding up. So some patients will report minutes feeling like hours, and others will report hours feeling like minutes. Altered emotions, so hallucinogens can cause emotions to change. Next is hallucinations. With hallucinogens, it's very frequently visual hallucinations. This differs from schizophrenia, which can have visual hallucinations, but most often causes auditory hallucinations. Though either of these can cause multiple types of hallucinations. It can be any sense, tactile, olfactory, visual, so on. Next is feelings of euphoria. So some of these make people feel really good or experience something that's really good. So that's sometimes why they're used. Other times they can cause bad trips though. And finally, many of these have different physical effects. So they don't just affect the brain, they also affect the body. So I found some interesting quotes from people that were using some hallucinogens. So 1 hour after the drug, someone said, when I close my eyes, then I have all these funny sensations, funny pictures. They're all in beautiful colors. They all look like Picasso's pictures. And the second quote is quite nice sounding as well. But once you go into 2 hours, some of the sentences seem less structured and a little more disorganized. For example, when I move my hands are very wet, and the lower part of my body, well, my body's bent. Freud, I think he went too far. So another additional interesting piece is you can look up psychedelic simulators on YouTube and see some of the waving patterns, some of the waving colors, and I think it's a good experience to see what some of these hallucinogens may cause in regards to visual perception. Next, I wanted to go into the DSM-5. So there are specific diagnostic criteria related to certain hallucinogen use. The major ones I want to focus on are the top 5. So it's interesting that Phencyclidine, which is PCP, has its own section, but this seems to be a historical artifact in the DSM because previous editions had PCP in a completely different section than hallucinogens. The DSM-5 group them all under hallucinogen-related disorders, but still have some separation there. So we have phencyclidine use disorder, other hallucinogen use disorder, phencyclidine intoxication, other hallucinogen intoxication, and a very interesting diagnosis called hallucinogen persisting perception disorder, which we will talk about. First in the DSM is hallucinogen use disorder. If you're familiar with the criteria for other use disorders, for example, opioid use disorder, alcohol use disorder, the criteria here is exactly the same, just replacing hallucinogen for the other terms. So this is the problematic long-term use of a substance, in this case, hallucinogens. So often taken in larger amounts, unsuccessful efforts to cut down, failure to fulfill major role obligations, so the person's missing school or missing work to use hallucinogens, cravings, tolerance, and so on. PCP or phencyclidine use disorder is the same criteria, just with PCP instead of hallucinogen, but there are a little bit of differences in phencyclidine intoxication versus hallucinogen intoxication. With that being said, the DSM-5 criteria is exactly what you would expect. So phencyclidine intoxication is someone uses phencyclidine and then has symptoms after. So this can be belligerence, assaultiveness, impulsiveness, so some pretty negative things, and then some physical symptoms like nystagmus, hypertension, and so on. Compare this to hallucinogen intoxication. So this is recent use of a hallucinogen and then having symptoms. They're not the same though in regards to belligerence and assaultiveness. They're more mental in regards to things like fear of losing one's mind, depression, ideas of reference, but then there are physical symptoms as well, like tachycardia, sweating, and so on. The next DSM-5 criteria I wanted to talk about was hallucinogen persisting perception disorder. So if you ever heard a person refer to, or a patient refer to, acid flashbacks, this can sometimes happen with hallucinogens. So days, months, years after use, the re-experiencing of the perceptual changes can occur, and this is called hallucinogen persisting perception disorder. So I hope that first section was helpful in covering some of the nicknames for the hallucinogens, separating them into subclasses, and then going over the DSM-5 criteria. So let's talk a little bit more about the effects. First, I wanted to start with the serotonergic-like group. So like I said before, these are structurally similar to serotonin, as you can see in the image on the screen, and they work on serotonin receptors just like serotonin would. More specifically, serotonergic-like hallucinogens stimulate the 5-HT2A receptor. And this is quite interesting because when you look at second-generation antipsychotics, they block dopamine and they block 5-HT2A. So it makes sense that our antipsychotics block 5-HT2A, and things that cause symptoms similar to hallucinations and psychosis stimulate 5-HT2A. Our examples here are LSD, psilocybin, mescaline, and DMT. So let's go into a little bit more detail about each of these. So LSD was first synthesized in 1938 by Albert Hofmann. He didn't really do much with this chemical for a few years, but a few years after he first synthesized it, he was remaking it and accidentally absorbed a little bit. And he noticed some strange effects, but then later wanted to try a higher dose to see if he could get more effects. So he took what he thought was a very, very small amount, which was around 200 to 250 micrograms. So we're not talking milligrams here, we're talking micrograms. So he thought that this was a very low, safe dose, but this turns out to be just the dose needed for LSD to have its effects. So LSD is a very potent chemical. There's something called Bicycle Day, and this was the day he first tried this real dose of the LSD, and he was riding his bicycle around when he started to feel the effects. So Bicycle Day is almost like an informal holiday within the hallucinogen community. So the quote that he said on Bicycle Day, "Little by little, I could begin to enjoy the unprecedented colors and plays of shapes that persisted behind my closed eyes. Kaleidoscopic, fantastic images surged in on me, alternating, opening, and then closing themselves in circles and spirals, exploding in colored fountains, rearranging and hybridizing themselves in constant flux." So quite an interesting description, and this is considered one of the purest uses of a hallucinogen because there was no preconceived expectations. No one had ever used LSD before, so this was all authentic. This was then later introduced as a commercial medication. There was some backlash in the 60s based on some CIA experiments, and it became a Schedule I drug and illegal. Like you would expect, as this being a serotonergic drug, a serotonergic-like hallucinogen, it works by stimulating 5-HT2A, and it works on 5-HT1A as well. Remember, 5-HT just means serotonin. How supplied and used? So LSD is so potent that it's often supplied as blotter paper. So as you can see the image with all the little bicycles, each of those would be a dose of LSD. So you can simply get a liquid LSD and put a little dot, a little piece of the liquid, and it absorbs into the paper. That's how potent LSD is. The effects can be seen here: energized, excited, overwhelmed, dilated pupils. You can have some heart rate changes, nausea. In toxicity with this serotonergic-like group, toxicity is typically not fatal, and mostly as you take too much of this serotonergic-like group, you have a bad trip. You are more likely to have a bad trip. One thing to note with LSD is its duration is quite long, up to 20 hours. It takes the liver a long time to clear this medication. So patients can have symptoms for quite a long period of time after using LSD. Next is psilocybin. So psilocybin is an active compound found in mushrooms and different types of mushroom, not just one type. The history goes way back. So there's imagery found in rock paintings suggesting that human use of psilocybin predates modern history. Mesoamerica has long-term use in religious ceremonies, and in 1959, psilocybin was isolated by the very same Albert Hofmann. Mechanistically, this works on serotonin. It's in the serotonergic-like group, so it's a 5-HT2A agonist. How it's supplied and used? Typically in raw mushroom form, dried mushroom form, and then people often make a tea out of this. Effects can be seen here: disorientation, lethargy, giddiness, euphoria, hallucinatory effects. There are some physical symptoms, but again, as a serotonergic agent, there's less physical symptoms, and more of the toxicity is related to having a bad trip. Duration is shorter than LSD, in being 8 hours. Next is mescaline. So anytime you hear a patient referring to a cactus or peyote or buttons, they're probably talking about mescaline. This, again, has a long history, over 5,000 years. Mechanism of action, it's a serotonergic-like hallucinogen, so it's a 5-HT2A partial agonist. How it's applied and used? Typically in cactus buttons, and these can simply be chewed upon, but they can also be mixed with water and drank. Effects can alter conscious, cause a dreamlike state, cause headaches, tachycardia, loss of coordination. Toxicity, so even though this is within the serotonergic-like group, this structure of mescaline is more similar to an amphetamine than it is to serotonin. So out of the serotonin-like hallucinogens, this one's probably the worst to overdose on because you do get your sympathetic nervous system activated in overdose. So it can cause tachycardia, agitation, muscle stiffness, ataxia, seizures, hyperthermia, so all bad things. So if someone's gonna take too much of a hallucinogen in the serotonergic group, you don't want it to be mescaline. Duration, up to 12 hours. Finally is DMT. So DMT is actually produced in many species of plants as well. It's used in Amazonian shamanic practices, and DMT is the active ingredient in ayahuasca. So I think that's very important to know additionally. This is a serotonergic-like hallucinogen, so its mechanism of action, 5-HT2A agonist. How it's applied and used, powders, crystals, you can smoke it, inject it, snort it, consumed in a tea, and that's when it's mixed with a few plants, often called ayahuasca. DMT can have a very intense trip because it has a very quick onset, meaning people will go from feeling perfectly fine to deep into their trip and then a quick offset as well. Toxicity can be seen there. This does work on serotonin as well as the other ones, so serotonin syndrome is a possibility. You can see the duration is very short with DMT, 15 to 60 minutes, but ayahuasca is much longer, effects up to 6 hours, and we'll talk about why on this next slide. So what is ayahuasca? Ayahuasca is when you take the vine of one plant and the leaves of another plant and boil the mixture together. The plants contain DMT and an MAOI. MAOIs are medications as well. So there are MAOIs that are prescription antidepressant medications. When you combine an MAOI with DMT, it prevents the metabolism of the serotonin and the DMT, so the effects last for much longer. So remember, DMT works for a very short period of time, but when you make ayahuasca, it lasts for a longer period of time. So in summary, with the serotonergic-like group, in overdose, the symptoms are typically neuropsychiatric. They're a little safer in overdose than some of the other hallucinogens. Overdose treatment is mostly symptomatic, but if the patient comes to the ED or something, they'll often be put into a quiet room, dim the lights, make it quiet, make it dark, things like that. Benzodiazepines can be used, and rarely antipsychotics sometimes are used. So next is a knowledge check question. So a patient took a hallucinogen 15 hours ago and is still feeling the effects. They are worried that the effects will never go away. Which hallucinogen did the patient most likely take? DMT, mescaline, psilocybin, or LSD? So feel free to pause and think about it. But if they're 15 hours in, the longest acting serotonergic-like hallucinogen is typically LSD. So that's most likely what this patient had taken. Next, I wanted to go into the dissociative group. So this group is characterized by working on NMDA. So in your brain, you have a primary inhibitory neurotransmitter. This is called GABA. And you have a primary activating neurotransmitter or excitatory neurotransmitter. And this is called glutamate. NMDA is a subtype of the glutamate receptors. So being an antagonist here or a blocker here is why these agents, some of them, were originally used for anesthesia. The medications here and substances here we'll be talking about are PCP, ketamine, and dextromethorphan. So let's start with PCP. So in the 1950s, this was originally marketed as an anesthetic under the trade name Cernal. 1960s, this entered the drug scene, and by the 1965, it was discontinued. Even while it was available to be used by doctors, most doctors didn't really like it because they would put the patient under anesthesia with PCP, and then the patients would wake up dysphoric, agitated, hallucinating. So doctors didn't really like PCP as an anesthetic. And then it is Schedule 2. How does this work? This is an NMDA antagonist. How supplied and used? White powder, oil, liquid, pills, and it's used by being snorted, injected, smoked, swallowed. The effects can be seen here. So sometimes they are positive, and that's why people like to use it. So it can be happy, upbeat, but they can also be negative, panicky, paranoid, aggressive, violent, feelings of superhuman strength. So you can watch videos on YouTube of police officers trying to apprehend people after they use PCP, and they'll be taking taser shots and baton hits, and they kind of just keep coming forward. So some of the effects of PCP can be quite scary. Toxicity of the NMDA antagonists can be a lot worse than the serotonergic-like hallucinogens. So you get sympathetic hyperactivity, hypertension, which means high blood pressure, rigidity, high body temperatures, your heart can beat really fast, seizures, and so on. PCP is very fat soluble, meaning it takes a long time for the body to clear it, up to 48 hours. Next is ketamine. So this, in 1963, was patented as a veterinary anesthetic. 1970s, available for human use under the brand name Ketalar, still available for human use. In Vietnam War, it was used as a field anesthetic. In 1999, it was made Schedule 3. This is also an NMDA antagonist like PCP, but it often has more chilling and relaxing effects rather than some of that assaultiveness or violence that can be seen with PCP. This is available as a powder, vial, tablet, and can be used in a few different ways. Effects are dreamlike detached state, chilled feeling, relaxed feeling, happy, but it can also be negative with confusion and agitation being possible. Some other physical effects are nausea, and it can stop pain responses as it is an anesthetic. Toxicity with ketamine can be quite bad as well, including encephalopathy, seizures, coma, acute kidney injury. Duration is relatively short as compared to PCP. Finally is dextromethorphan in this group. So this received FDA approval as a cough suppressant in 1958. In the 70s, it was available over the counter under a brand name Romalar, and it was flying off the shelves, mostly because people were buying it to misuse it and drink a lot of the cough syrup, which actually tasted quite good as well, and they would hallucinate from it. Romalar was then allowed to go back on the shelves, but they had to make it taste less good. Finally, in 2010, it received FDA approval in combination with quinidine for pseudobulbar affect. Dextromethorphan is also an NMDA antagonist, supplied as a tablet, liquid, powder, but what you'll most commonly see is younger people, usually teenagers, buying a lot of Robitussin or other cough syrups that have dextromethorphan, and they have to drink quite a bit to get the hallucinatory effects. The effects can be euphoria, visual and auditory hallucinations, but they can also be negative, agitation, paranoia, feelings of floating. Some of the physical effects aren't that good if someone has to drink a lot of cough syrup to get it. So nausea, vomiting, sweating, hypertension. Toxicity can be seen on the slide, and the duration is 3 to 6 hours. In overdose, the dissociative group or the anesthetic group is much worse than the serotonergic-like group. There are more fatalities in overdose with these agents. Treatment is supportive care. Sometimes you have to acidify the urine with PCP intoxication. You can use activated charcoal to clear it faster. Sometimes you need benzodiazepines, antipsychotics, or clonidine. Finally, kind of in a class of its own is NMDA, which is often called ecstasy, and some people call it purified form Molly. This is serotonergic in that it's a 5-HT2A agonist, just like the serotonergic hallucinogens, but this is also has effects similar to an amphetamine. The MA in MDMA stands for methamphetamine. So this causes big releases and prevents the reuptake of dopamine and norepinephrine. So MDMA is almost like a hybrid between a hallucinogen and a stimulant. It has the effects of both. History: this was first developed by Merck in 1912. 1970s, it was used during therapy to enhance the effects. In the 1980s, it was commonly used as a street drug. So mechanism of action I touched upon, 5-HT2A agonist, and increases dopamine and norepinephrine. Most commonly supplied in colorful pressed tablets, but it can be in other formulations as well. The effects can be seen here. So people can get very happy, have loving feelings, euphoria, feeling energized, alert, and they can also get the stimulatory effects like feeling energized and alert and feeling anxious. There can also be negative effects like confusion and paranoia. You often hear of this causing dehydration and raised body temperatures, especially when people are using this in a club or a scene where there's not much water to drink and maybe alcohol that's also dehydrating the person, and they can also be dancing and raise their body temperature. So it is possible to have quite negative effects from MDMA. Toxicity is not great. It can be seizures, vomiting, serotonin syndrome, hyperthermia, hyponatremia, and their duration is relatively short. In overdose with MDMA, there can be negative effects. You do supportive care, monitoring, you can do activated charcoal. Sometimes you'll have to aggressively cool the patient, and you can use a skeletal muscle relaxant called dantrolene in severe cases. Finally, I wanted to briefly touch on other hallucinogens. So there are a lot more than these three. There are plenty of other hallucinogens, but these are some I wanted to just touch on briefly. So first we have Salvia. So this is a hallucinogenic plant native to Mexico. About 10 years ago, it became relatively popular because it was still considered legal, so many teenagers and young people would use it. This is actually a kappa opioid receptor agonist. So when you think of pain medications, those are mu opioid receptor agonists. This doesn't affect mu, so it's not similar to like fentanyl or morphine or heroin. This just affects kappa opioid receptors. So this doesn't cause euphoria, it causes dysphoria in addition to the hallucinations. So often people don't use salvia more than once. Effects are intense hallucinations, mixed feelings, mood swings, all sorts of stuff, and the duration is relatively short. Next is Jimson weed. So this is a wild herb found in the United States, and this is very anticholinergic. So it has pretty negative effects in use and in overdose. So again, people don't typically use this many times, but sometimes teenagers will use it. Finally, there are many chemical synthetic products. One that I wanted to touch on is called N-Bomb. So this is a synthetic hallucinogen that's used in biochemistry brain mapping because it's so strong of a binder at 5-HT2A. So this is essentially like a more potent version of LSD. And it sometimes has more negative effects than LSD because remember, if you take too much LSD, you can have a bad trip. So this is essentially like a stronger version of LSD. Finally, I wanted to briefly review some medical literature. So if patients are asking you questions about this, it's good to be somewhat educated on what's out there. We'll start with LSD, and surprisingly, there's not as much published medical literature as I thought there would be. I found a meta-analysis of 11 articles that use a big range in the dosing. So 20, which is quite low, to 800, which is very high. And there wasn't much evidence for medical use, though there was some for alcohol use disorder. Next, I found a small trial of 12 patients with life-threatening diseases like cancer and other life-threatening diseases, and LSD-assisted psychotherapy did help their anxiety scores. Next is psilocybin. So a 27-patient trial found that psilocybin had positive effects in major depressive disorder. And this was psilocybin-assisted therapy. So many of the trials are using therapy in addition to the hallucinogen, not just using the hallucinogen alone. So around 70% of patients had a response, and 55 were in remission from depression, which is quite high numbers with how difficult depression can be to treat. Next, there was a small study that showed that psilocybin may have some long-term personality benefits. So 1 year after use, patients scored higher in their openness and their empathy scores. Next is mescaline, and this here is a safety trial, not an efficacy trial. So compared with Navajos with minimal substance use, the peyote group showed no significant neuropsychological deficits, whereas the former alcohol use did show neuropsychological deficits. So it doesn't seem like, at least in this patient population, multiple uses of mescaline in the past didn't affect neuropsychological outcomes, though alcohol did. Finally, next, DMT is in phase 2A trials to be used in the treatment of major depressive disorder, so more to come about this. Next was a trial of ayahuasca in substance use disorders, and you can see tobacco use decreased, alcohol use decreased, and cocaine use decreased after ayahuasca. PCP, I couldn't really find any strong studies for its benefits, but there were many studies on how to treat PCP psychosis or intoxication. Ketamine does have a lot of evidence, so relatively a lot of evidence in regards to depression. So ketamine demonstrated rapid antidepressant effects in 24 hours, which remember, SSRIs, SNRIs can take a few months before they reach their full effects. Ketamine decreased suicidal thoughts. Ketamine decreased PTSD scores in another trial. And S-ketamine, another version of ketamine, is available in a nasal spray, and it's FDA approved for treatment-resistant depression. Next is MDMA. So MDMA assisted psychotherapy, so using this in conjunction with therapy, has a few trials that show benefits in PTSD. So this might be a future treatment for really treatment-resistant PTSD. And I've worked at 2 VAs in my career, so I'm really interested in PTSD treatments. There's also positive evidence for treating anxiety in autistic adults, and they're planning trials in eating disorders. Dextromethorphan has many trials about its use, but mostly in cough suppression, pseudobulbar affect, Parkinson's disease. I couldn't find much other evidence. So knowledge check. Patient at the VA hospital has very refractory PTSD and says he was enrolled in a trial to use a hallucinogen while receiving therapy. Which substance is the patient most likely referring to? So feel free to pause and think about it. But based on the current literature that's out there, this patient was most likely in an MDMA trial. That being said, all the evidence isn't positive. There are some negative outcomes with hallucinogens. So in this trial, 30% of people who used hallucinogens reported extreme fear after psilocybin. 39% reported that their worst bad trip was among the 5 most challenging experiences of their lifetime. Nearly all of the participants had experienced bad trips, which they classified as panic attacks, confusion, and disturbing visions and paranoia. Additionally, hallucinogen persisting perception disorder is another negative. So 5 to 50% reported having experienced at least one flashback to their use. And I found a case report where a person was having flashbacks 13 years after their use. Next, there is a little bit of evidence that relatively high doses of ecstasy, which is MDMA, used relatively frequently can cause potentially some neurotoxicity in rat and primate studies. So knowing if this translates into human studies would be quite important to know. So in summary, we talked about hallucinogens, we went over some background and went into some of their street names and differences in their mechanism of actions based on subcategorizations. Then we went through the DSM-5 criteria. Then we went over some of the effects and really separated them between the serotonergic-like group, the dissociative-like group, MDMA, and then some of the other hallucinogens. There are positive studies for use, but there are also potential negatives. So having more trials is really important at this point in time. So this summarizes the table of contents, and I hope this presentation was helpful, and thank you so much for watching.